All right, chapter 29, physical activity and immobility. Again, the disclaimer, I don't own this material. Under fair use, I am providing lecture content for my nursing students only using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. All right, so the concepts that we're doing in this chapter are mobility, fitness, physical activity, and exercise. What do we need physical activity for? Well-being, fabulous. So physiology of movement. When you are talking about orthoneuro, right? That's what we're talking about. Mobility, movement, muscles, bones, nerves. So, skeletal system, muscles, motor nervous system. Body mechanics, alignment, balance, coordination, joint mobility. It's not that you understand these until it's gone, right? When you don't have good body alignment, that's when you feel the pain. When you don't have balance, that's when you fall. When you don't have coordination, that's when you fall. When you don't have mobility in your joints, that's when you notice. These are one of these things that we don't take advantage of it while we have it. We notice it when we don't have it. So, just from personal experience, avoid injury. Avoiding injury looks like using proper alignment when you're moving a patient up in bed. Having a wide base of support. Avoid bending over, twisting, squatting to lift. Keep objects close when you're lifting. Raise beds. Push versus lift. Get help. I cannot tell you how many times people will say, "Oh, shouldn't you have used the Hoyer for her?" "Oh, I didn't have time. No one was available." A lot of the times you hurt yourself, and workers' comp is not going to pay for that because you should have been using a lift, extra people. All right, so clicker check. To maintain proper posture, it's important to sleep on the softest mattress possible. Avoid arching shoulders forward when sitting. Keep your knees locked when standing upright. Keep your stomach muscles relaxed to prevent back spasms. Thought process. Sleeping on the softest mattress possible will make your body, your spine go out of alignment. That's why you're never supposed to sleep on the couch. Couch has a soft mattress. All right? Keep your knees locked while standing upright. That's a good way to fall. When you go into the OR, they tell you don't lock your knees. Right? Keep your stomach muscles relaxed. Usually they say suck it in. All right, so body alignment. Making sure that your arms, your shoulders are back. So don't slouch forward, especially over your computer, especially over your cell phone, right? So different types of exercises, different reasons to do each. Isometric exercises, isotonic, isokinetic, aerobic, anaerobic, aerobic with oxygen, anaerobic without oxygen. isokinetic movement, kina, movement, isotonic, isometric. Make sure you know what these are. Benefits of exercise. What are the benefits? What is the bad part of it, right? It's kind of like when people ask you, what's the benefits of breastfeeding? Everything. Benefits of exercise. Going to improve cardiovascular health. Going to increase muscle tone and flexibility. That'll be key on the tests when you have an older adult. When you have osteoarthritis, rheumatoid arthritis, the answer will never be, oh, just sit on the couch and do nothing. Enhance immune system. Promote weight loss. Decrease stress. Increase overall feeling of well-being. Exercise program. There are flexibility trainings, resistance trainings, aerobic conditioning. We use them for different things. Know them. Flexibility in being flexible, especially when you get older. Resistance training, building up muscle. Aerobic conditioning, that's like your cardiovascular patients. They go through aerobic conditioning. Cardiac rehab is trying to get them back to doing ADLs without being out of breath and having chest pain. Benefits: lower risk for early death, heart disease, stroke, diabetes, hypertension, hyperlipidemia, metabolic syndrome, colon, breast cancers, depression. The risks would be injury, right? If you overdid it. Could you have a heart attack exercising? Sure, people do every day, right? You always hear about those people that were out for their 5-mile run and dropped dead of a heart attack in the middle of a marathon, whatever. Musculoskeletal injury, especially the Achilles tendon, pulling a muscle. Yeah. Dehydration, if you don't have enough fluid on board, you can easily get dehydrated, especially here in Florida or when it's hot. And then temperature regulation. If you are somebody who cannot regulate your temperature, you could put yourself into overheat, like being in a furnace. Okay. Factors affecting mobility and activity. Developmental stage, nutrition, lifestyle, environmental factors. Musculoskeletal system disorders. Just going straight down the list here. Congenital anomalies of the musculoskeletal system. Congenital anomalies means that they happened in utero before you were born. What could that be? Could be an extra finger, could be anything with the musculoskeletal system that's a congenital anomaly. The ones that I think of the most with kids and bone are typically like bow leg, right? When your legs bow out. Could be muscle issues, could be brittle bone, right? So lots of different things it could be. What could be considered under here could be multiple things, depending on the age of the patient. Diseases related to bone formation or metabolism. Here you go. Brittle bone, arthritis, juvenile arthritis, rheumatoid arthritis, osteoarthritis. You need to know what those are and why they affect mobility. Diseases that affect joint mobility. Your joints, rheumatoid arthritis, juvenile arthritis. Bone integrity, brittle bone. Hypercalcemia, too much calcium. Trauma, broken bone. Anybody not broke their leg? Typical as a child, falling down from trees, whatever. And then disorders of the central nervous system. MS, Lou Gehrig's, things like that. The assessment is based on the focused nursing history and a focused physical assessment. So again, physical assessment, why do we do it? Focused assessment. Nursing diagnoses with this: activity intolerance, impaired physical mobility, risk for disuse syndrome. Disuse syndrome is I can't use it or I don't use it. Think about that with a stroke. If you don't know there's a left arm, you're not going to use it. Sedentary lifestyle. Sedentary lifestyle, calcium reabsorption from the bone, not having weight-bearing exercises will put you at risk for osteoporosis, male or female. Planning outcome interventions, energy maintenance, and mobility. Our goal with mobility is to get them back to their highest level of functioning and maintain their energy in doing so. So energy maintenance, especially important with a cardiovascular issue, but maintaining energy as much as we can. That means clustering care. If you're going in the room, do it and get it done with. Let them rest for energy maintenance. Clicker check. Which of the following interventions for the client who is immobile should the nurse give priority to? A patient's immobile, what happens? Encouraging a diet high in fiber and extra fluids. B. Administering the PRN medication for sleep. C. Have the client use the incentive spirometer every 2 hours. D. Massaging the client's legs every hour. Think about this. Nursing priority. Nursing priority. A, B, C. Encouraging a diet high in fiber and extra fluids. Sure, that's great. I should do it. But what's the worst that's going to happen? He gets constipated? ABC? Not really. Administering the PRN medication for sleep. Priority? Massaging the client's legs every hour. That's a great way to move a DVT. Massaging the client's leg is probably not going to be the answer. Okay? A, B, C. What is an incentive spirometer? It incentivizes them to take deep breaths. One of the biggest risks with being immobile is atelectasis or pneumonia. Atelectasis is taking small breaths and not opening up the bottom of the lungs. Pretty soon you're going to end up with pneumonia. So anybody who's immobile, airway, breathing. What happens if I don't use the incentive spirometer? Get pneumonia, die of pneumonia, lung consolidation. Okay. So C, it improves oxygenation. It prevents atelectasis. So that is our priority intervention from that list that was listed. All right, promoting exercise. What do? Got to start somewhere. What does that sound like? Assess, diagnose, plan, intervene. Assess what they're able to do. Plan and vary the exercise routine, make it fun. Use the buddy system, rewards. Integrate exercise into routine activities. How do you do that? Integrate exercise into routine activities. You tell them park at the end of the Publix parking lot and walk to the store and walk back to the bag with the bags to the car. Incidental exercise, right? Taking the stairs, not the elevator. Things like that. And then attaining a target heart rate. So they should know what their target heart rate is when you're making a plan. Make something fun, right? If you don't like to run, why are you running 3 miles a day? That's not going to be something that you're going to sustain. Tips for successful exercise routine. Not all physical activity has to be exercise. Wear good shoes. Stretch and warm up before you start. Maintain exercise intensity for 30 to 40 minutes. Alternate exercise activities. Stay hydrated. In the hospital, we want to promote activity. So in activity, we want to make sure that they have a proper alignment of their hospital bed. Make sure that you put your bed up. Make sure they're in the right alignment when they're in bed. Use range of motion activities. That could be assisted or passive. Assisted, active range of motion means you tell them which way to do it and they do it. It's active. Passive is you putting those joints through the motions. Passive, you're doing it. Active, they're doing it. Incorporate pillows, wedges, side rails, trapeze, footboards, sandbags, trochanter rolls, splints to keep alignment straight. So let's talk about the pillow. This is an abduction pillow. It keeps the feet apart, especially when you've replaced the hip on a patient. When you replace the hip on a patient, they are more than likely going to want to cross their legs. That pops the new joint out of the joint. Abduction pillows look like an A for abduction, abduction away, adduction, ADD towards. Okay? Know your positions for patients. Know why we use the positions for patients. That's on your NCLEX cheat sheet that I've already put in the announcements. Fowlers, what does that look like? Lateral, what does that look like? Prone, why do we use that? Sims position, why do we use that? Supine, why do we use that? Why would we not want to use one? I can't tell you how many times the NCLEX questions have to do with positioning of patients. When you are moving a patient up in bed, we were talking about log rolling. Log rolling means that there's a spine that's potentially injured. You will have orders to log roll the patient. That means there needs to be one nurse just with the head, and the CNAs can move the body. But the nurse, critical thinking, has to hold the neck in alignment. Turning a patient in bed, moving a patient in bed, that's what we did last week in the lab. Make sure that you do it this week in the lab so that you solidify that information in the ATI. The use of a transfer board. You did this in the lab. A transfer board can also be a piece of plastic that you use to get a patient over in bed or over from a stretcher to a bed. You can also use a hover mat if anybody's used those. And then, of course, you have your transfer board, which we used in the lab. Mechanical lift I brought in. Maybe we can do that this week if there's extra time. So a mechanical lift is anybody more than like probably 300 pounds. You probably should put them in a mechanical lift. Do not do it by yourself like this lady is. You need to have two people. One person to watch the patient and one to move the lift, right? These can be found in most hospital rooms because more people are hurting their backs. They are at least one or two in most units nowadays, especially those that do bariatric surgery because our patients are so big. The transfer belt, you heard them talk about the transfer belt. Make sure you're using it. And then assisting with ambulation. This might require conditioning exercises. If the patient's been bedridden for quite some time, we might need to do some conditioning. Physical therapy helps us with that. Obtain appropriate assistive devices, cane, crutch, walker, wheelchair, all those good pieces of equipment. Clicker check. All right, clicker check. True statement about the device used when assisting clients to ambulate. The client should stand a foot back from the back legs of the walker. A cane should be used by the client to support the weakest side of the body. Carefully reread that. A cane should be used by the client to support the weakest side of the body. A transfer belt should be placed around the client's chest for maximum lift. Each crutch walking gait begins with the client in the tripod position. Which one is true? How did we tell you to stand in the walker? You push it 6 inches in front of you and move into it. So 6 inches and a foot are a lot different. I'm not going to push it back a foot. You should not stand a foot back from the back legs of the walker. And especially if it has wheels, because that's going to make the walker go. The client with the cane should be supporting the strong side. It should be on the strong side of the patient. Transfer belt should not be on the client's chest. Transfer belt should be at waist level. All right, tripod position is the basic crutch position when you start. Socratic reasoning, let's go. A female client has been immobile for 2 months prior to spinal fusion surgery. After the procedure, the client wants to get out of bed and walk, even though the surgeon prescribes bed rest for 2 days. What should you assess prior to assisting this patient out of bed? What do you assess? If the patient's supposed to be on bed rest for 2 days, why are we getting her up? Right? Here's my question. Can you do a double win, right? Here's the thing. Most people just want to get up to the bedside. Are they still in bed? If she's been immobile for 2 months prior to surgery, I guarantee you she probably will not be able to stand on her feet and balance. I would get her up to the side of the bed, just on the bed, in the bed, and let her dangle, and then put her back. If you have her stand up, she may fall and ruin that surgery, right? Ask the client, what do they want? They probably just want to dangle. Can they dangle? The question is, how bad was his spinal fusion surgery, right? That's my bigger question. I don't want to be messing with that spine, especially if there's orders for bed rest for 2 days, especially if we're still log rolling this patient. I don't want to be the one to mess up that surgery. I'll go ask another person. I don't want to be in trouble. Can I even put her head up? What type of exercises should the client perform before ambulating? Dangle, march in place at the side of the bed. Can they even stand? That's the question. What can you do or teach the client to reduce the hazards of immobility? Drink, 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 fiber, incentive spirometer, right? The hazards of immobility is going to be constipation, pneumonia, blood clot. What else? What can you teach on blood clot? You can teach them how to pump the gas pedal to their car. So if they weren't to have SCDs on, sequential compression devices, we would tell them push your foot down like you're pressing on the gas pedal. Every time a commercial comes on, do 5, 10 of those. Okay? That gets blood back to the heart. Immobility. Whenever you have a leg sitting on a bed, this part is sitting on the bed, the compression of the blood vessel can cause clotting. Okay? Constipation because they're not drinking enough. Constipation because they're getting too many narcotics for pain. So, safe and effective care. The basis for safe, effective nursing care is thinking, doing, and caring. Thinking, doing, and caring. Think when you're caring for an older client who needs assistance to ambulate and change positions in bed. When preparing to ambulate, the client refuses to use the prescribed cane. What should you do to support the client's safety and psychosocial needs? How do we do this? Think, doing, caring. Older client needs assistant to ambulate and change positions in bed. When preparing to ambulate, he refuses to use the prescribed cane. Some people you can use humor. Hey, wait, did you forget this? Oh, I don't want to use that. But it's for your safety, right? Some people you can use humor. Otherwise, here's the question. Do you want to fall? Right? Saying it in a nice way. We're here for your safety. We just want you to be safe. Please don't get out of bed by yourself. We are here to keep you safe. Make sure there's non-skid socks on, right? Some people don't want to use the cane. It's prescribed. Thinking, doing, caring. Thinking, try to get them to use it. Doing, try to get them to use it. Is there something else he would use? Maybe he has his own cane. Caring, I know, Papa, but guess what? We love you. Can get you a long ways. We just don't want you to get hurt, Bubba. Some patients consider the use of aids a sign of weakness, inconvenience, and resist them. However, most people dread loss of independence, So you can always promote the use of walking aids by stressing their value in keeping them independent. They also like to know that you care, right? So if you say, well, you know, your daughter's going to be upset with me if you don't use it, you can use a lot of different tactics in this way. All right, talk to you later.